Hello, dear student. I am Lilit Sevoyan, the Assistant of Chair of Rheumatology. Today, I want to present you my presentation, my online lectures about polymyositis, dermatomyositis, inclusion body myositis, and Sjogren syndrome. Let's start. Let's start from definition. The inflammatory myopathies represent the largest group of acquired and potentially treatable causes of skeletal muscle weakness. They are classified into three major groups: polymyositis, dermatomyositis, and inclusion body myositis. Epidemiology. The estimated incidence of dermatomyositis is 9.63 cases per million population. It is very rarely disease. Dermatomyositis can occur in people of any age. Two peak age of onset exist. In adults, the peak age of onset is approximately 50 years, whereas in children, the peak age is approximately 5 to 10 years. Dermatomyositis and polymyositis are twice as common in women as in men. Neither condition shows any race. Inclusion body myositis is 3 times more frequent in men than in women, more common in whites than blacks, and it most likely to affect persons age up more than 50 years old. Etiology factors. The cause of dermatomyositis is unknown, like in many autoimmune diseases. However, genetic, immunologic, infection, and environmental factors have been implicated. A genetic component may predispose to dermatomyositis. Dermatomyositis rarely occurs in multiple family members, but a link to certain human leukocyte antigen types, for example DR3, DR5, DR7, may exist. Polymorphism of tumor necrosis factor may be involved. Immunologic abnormalities are common in patients with dermatomyositis. Patients frequently have circulating autoantibodies against the cytoplasma or nucleus. Abnormal T-cell activity may be involved in the pathogenesis of both the skin disease and a muscle disease. In addition, family members may manifest other diseases associated with autoimmunity. Antinuclear antibodies and antibodies to cytoplasmatic antigens, antitransfer RNA synthetases may be present. Although their presence may help to define subtype of dermatomyositis and polymyositis, their role in pathogenesis is uncertain. Some infection agents have been suggested as possible triggers of dermatomyositis. These include the following: viruses, for example, Coxsackie viruses, parvoviruses, echoviruses, human T-cell lymphotrophic virus type 1, HIV, and also we discussed the role of Toxoplasma or Borrelia. And also the cancer cells. Cells can have a role in etiology of dermatomyositis. There are too many agents that can cause muscle weakness. The other agents: statins, penicillamine, anti-tumor necrosis factor drugs, anti-programmed cell death drugs, interferon, cyclophosphamide, hinidine, phenylbutazone. Dermatomyositis also may be initiated or exacerbated by silicone breast implants or collagen injection. But the evidence for this is anecdotal and has not been verified in case-control studies. One report only detailed etiological differences among women in whom inflammatory myopathy developed after silicone implants. Well, we've already discussed the epidemiology and etiology factors, and let's go to pathogenesis. Dermatomyositis is considered to be the result of a humoral attack against the muscle capillaries and small arterioles, endothelium of the endomysial blood vessels. Since 1966, there has been evidence supporting an ongoing microangiopathy. In polymyositis, we have no microangiopathy and we have no skin lesions. The disease starts when putative antibodies or other factors activate C3 complement component, forming C3b and C4b fragments that lead to formation of C3b neo and membrane attack complex, MAC, which are deposited in the endomysial vasculature. Complement C5b9 membrane attack complex is deposited and is needed in preparing the cell for destruction in antibody-mediated disease. B cells and CD4 helper cells are also present in abundance in the inflammatory reaction associated with the blood vessels. When we talk about polymyositis, we have CD8 cells, not CD4 cells. And also I've said that we don't have vasculopathy, and that's why we don't have the skin lesions. The pathogenesis of the cutaneous component of dermatomyositis is poorly understood, but is thought to be similar to that of muscle involvement. Studies on the pathogenesis of the muscle component have been controversial. Some suggest that the myopathy in dermatomyositis is pathogenetically different from that in polymyositis. The former is probably caused by complement-mediated terminal attack complex vascular inflammation. The latter by the direct cytotoxic effect of CD8 lymphocyte on muscle. However, other cytokine studies suggest that some of the inflammatory process may be similar. One report has linked tumor necrosis factor abnormalities with dermatomyositis. Let's talk a little about clinical features. In dermatomyositis is a disease that primarily affects the skin and the muscles. In polymyositis, we don't have affect the skin, but may also affect other organ systems. The possibly pathognomonic cutaneous features of dermatomyositis are a heliotrope rash and Gottron papules. In this slide, you see the Gottron papules in the fingers and the heliotrope rash, which is the periorbital rash, violet or red rash in periorbital areas. In dermatomyositis, we have characteristic but not pathognomonic features, including the following: malar erythema, poikiloderma in a photosensitive distribution, violaceous erythema on the extensor surfaces, periungual and cuticular changes, poikiloderma, which consists of erythema, hypopigmentation, hyperpigmentation, and telangiectasias, One more time: erythema, hypopigmentation, hyperpigmentation, and telangiectasia. And when we have the in lateral tides, its name was Hoster sign. And also we can have in a V-neck configuration, and we're now going to see the image of V-neck configuration poikilodermia. And then one more symptom is mechanic's hand. Here is a picture of mechanic's hand. Here is the poikilodermia. I have mentioned above. You see the erythema, you see the hyperpigmentation, hypopigmentation, and telangiectasias. Let's talk about the pathognomonic rash in dermatomyositis in detail. The heliotrope rash consists of a violaceous to erythematous rash, with or without edema, in a symmetrical distribution involving the periorbital skin. Sometimes this sign is subtle and may consist of only a mild discoloration along the eyelid margin. Similar to other areas, scale may be present on the eyelids. A heliotrope rash is rarely observed in other disorders. Therefore, its presence is highly suggestive of dermatomyositis. Pay attention, its presence is highly suggestive of dermatomyositis. Then, Gotron papules. The image you are seeing also are flat-taped erythematous to violaceous papules and plaques found over bony prominences, particularly the metacarpophalangeal joint, the proximal interphalangeal joint, and or the distal interphalangeal joint. They may also be found overlying the elbows, the knees, and or the feet. A slight scale overlying the papules may be present, and occasionally a thick psoriasiform scale is observed. Gotron papules may clinically resemble lesions of lupus erythematosus, lichen planus, or particularly in the event of psoriasiform scaling or psoriasis. Extramuscular manifestation. This may be present to a varying degree in patients with polymyositis or dermatomyositis and include some systemic symptoms such as fever, malaise, weight loss, arthralgia, Raynaud's phenomenon, especially when inflammatory myopathy is associated with a connective tissue disorder. Some joint contracture, mostly in dermatomyositis and especially in children. Dysphagia and gastrointestinal symptoms due to involvement of oropharyngeal striated muscles and upper esophagus, especially in dermatomyositis and inclusive body myositis. Cardiac disturbances, including atrioventricular condition, defects, tachyarrhythmias, dilated cardiomyopathy, a low ejection fraction, and congestive heart failure, which may rarely occur either from the disease itself or from hypertension associated with long-term use of glucocorticosteroid. Don't forget that glucocorticosteroid is the first-line therapy for inflammatory myopathies. Pulmonary dysfunction due to weakness of the thoracic muscles, interstitial lung disease, or drug-induced pneumonitis. For example, from methotrexate, which may cause dyspnoea, non-productive cough, and aspiration pneumonia. Interstitial lung disease may precede myopathy or occur early in the disease and develops in up to 10% of patients with polymyositis or dermatomyositis, most of whom have antibodies to tRNA synthetases as described below. Subcutaneous calcification or calcification cutis in dermatomyositis, sometimes extruding on the skin and causing ulceration and infections. Arthralgias, synovitis, or deforming arthropathy with subluxation in the interphalangeal joint, which can occur in some patients with antisynthetase syndrome. Muscle disease commonly manifest as a proximal symmetrical muscle weakness when we talk about dermatomyositis or polymyositis. In inclusion body myositis, both proximal and distal muscles are involved in processes. The degree of weakness may range from mild to moderate to severe. Sometimes quadriceps is observed. That's why the person are full very often. Patients may have difficulty rising from a chair or squatting and then raising themselves from this position. Sometimes, in an effort to rise, patients use other muscles that are not as affected. Testing of muscle strength is part of each patient assessment. Often the extensor muscles of the arms are more affected than the flexor muscles. Distal strength is almost always maintained. Neck flexor weakness may also be seen. Muscle pain and tenderness may be observed early in the course of the disease. Muscle tenderness is a variable finding. Sensation is normal, and tendon reflexes are preserved unless the muscle is severely weak and atrophic. Other systemic features include joint swelling, changes associated with Raynaud phenomenon, and abnormal finding on cardiopulmonary examination. When joint swelling occurs, the small joint of the hands are the most frequently involved. The arthritis associated with dermatomyositis is non-deforming. Patients with pulmonary disease may have abnormal breath sounds. Patients with an associated malignancy may have physical finding relevant to the affected organ. Ocular muscles. Ocular muscles are spared, even in advanced, untreated cases. If these muscles are affected, the diagnosis of inflammatory myopathy should be questioned. Association with malignancies. Although all the inflammatory myopathies can have a chance association with malignant lesions, especially in older age groups, the incidence of malignant condition appears to be specifically increased only in patients with dermatomyositis and not in those with polymyositis or inclusion body myositis. The most common tumors associated with dermatomyositis are ovarian cancer, breast cancer, melanoma, colon cancer, and non-Hodgkin's lymphoma. Let's repeat it one more time. The ovarian cancer, the breast cancer, melanoma, colon cancer, and non-Hodgkin's lymphoma. In the table 1, we see the criterion supporting the diagnosis of inflammatory myopathies. Here is the pattern of muscle weakness. In dermatomyositis, we have subacute onset of proximal symmetric weakness In polymyositis, we have also the subacute onset of proximal symmetric weakness. In inclusion body myositis, it's very important that we have slow onset of proximal, and not only proximal but also distal weakness. Atrophy of quadriceps and forearms, frequent falls due to quadriceps lesions. Mild facial muscle weakness in people older than 50 years of age. When we talk about creatine kinase level in dermatomyositis, in polymyositis, and occlusion body myositis, we have high level of creatine kinase. In dermatomyositis, up to 50 times. In polymyositis, up to 50 times, and in inclusion body myositis, up to 10 times the upper limit of normal. Sometimes in inclusion body myositis can be normal or slightly elevated. Electromyography, myopathic units we have in dermatomyositis, polymyositis, and inclusion body myositis. And when we talk about muscle biopsy, in dermatomyositis we have vasculopathy and CD4 proliferation. When we have polymyositis, we have CD8 cells proliferation and don't have the imaging of vasculopathy. In inclusion body myositis, we have CD8 cells and vacuoles also. Autoantibodies, anti-Me2 antibody in dermatomyositis, anti-Jo1 antibody in polymyositis, anti-CN1A antibodies in inclusion body myositis. As we see in table 1, the classification criteria, we have some approach consideration. When people come to us with muscle weakness, the workup for us is selected laboratory tests, diagnostic imaging, for example, magnetic resonance imaging, chest radiography, ultrasonography, electromyography, or computed tomography, as well as muscle and skin biopsy and other tests as appropriate. In adult patients with dermatomyositis, assessment for malignancy should be performed upon initial diagnosis and repeated at least annually for 3 years. The risk of malignancy increases with age. The exact testing order should be based on the patient's sex, age, and race. However, testing beyond age-appropriate screening is most often recommended. Let's talk about laboratory tests. The most sensitive specific enzyme abnormality is elevated creatine kinase. But Aldolase studies and other tests, for example, aspartate aminotransferase or lactate dehydrogenase, may also yield abnormal results. Several serologic abnormalities have been identified and may be helpful in classification of subtype for prognosis, but they are not used for routine diagnosis. As a group, these antibodies have been termed myocyte-specific antibodies, MSAC. These autoantibodies occur in about 30% of all patients with dermatomyositis or polymyositis. A positive antinuclear antibody finding is common in patients with dermatomyositis, but is not necessary for diagnosis. Anti-Me2 antibodies are highly specific for dermatomyositis, but sensitivity is low. Only 25% of patients with dermatomyositis demonstrate these antibodies. These autoantibodies are associated with acute onset classic dermatomyositis, including the VNAC sign and shown rash, as well as a relatively good prognosis. Anti-Jo1 antibodies are common in patients with polymyositis but may occur in patients with dermatomyositis. They are associated with pulmonary involvement, interstitial lung disease, Raynaud phenomenon, arthritis, and mechanic hand in the setting of the anti-synthetase syndrome. Other myocyte-specific autoantibodies include anti-signal recognition protein, anti-CRP, which is associated with which is associated with severe myositis, anti-PM, SCL, and anti-Q, which are associated with overlapping features of myositis and scleroderma, and anti-NXP2, which is associated with calcinosis in the juvenile population and more recently in the adult population as well. An autoantibody directed against 155 kilodalton protein known as anti-P155 and 140. Imaging studies. MRI may be useful in assessing for the presence of an inflammatory myopathy in patients without weakness. It can assist in differentiating steroid myopathy from continued inflammation and may serve as a guide in selecting a muscle biopsy site. Ultrasonography of the muscle has also been suggested for evaluation, but has not been widely accepted. Electromyography is a means of detecting muscle inflammation and damage, and has at times been useful in selecting a muscle biopsy site. Since the introduction of muscle MRI, EMG has been obtained less commonly in this setting. A bottom swallow allows evaluation of esophageal dysmotility. CT scanning of the chest, abdomen, and pelvis is useful in the evaluation of potential malignancy that might be associated with dermatomyositis. Transvaginal ultrasonography of the pelvis is particularly important for malignancy screening in women. Given the strong association between ovarian cancer and dermatomyositis, mammography is also useful in women for the evaluation of a potential malignancy. And other studies. Muscle biopsy, pulmonary function studies, electrocardiography, esophageal manometry, age-related colonoscopy and fecal occult blood testing for malignancy screening, pap smear in women for malignancy screening, cancer antigen 125, CA125 and CA19-9 for malignancy screening. Muscle biopsy, either open or via needle, may enhance the clinician's ability to diagnose dermatomyositis. The biopsy results may be useful in differentiating steroid myopathy for active inflammatory myopathy when patients have been on corticosteroid therapy but are still weak. In this diagram, you see the treatment of inflammatory myopathies, a step-by-step approach. When we have initiation of therapy, we use prednisone 1 to 2 milligram per kilogram up to 100 milligram per day for 4 to 6 weeks, and then taper to alternate days. When we talk about inclusion body myositis, we use physical therapy, participation in research trial. When weakness at onset is severe or rapidly worsening, Intravenous glucocorticosteroid we can use. It is the pulse therapy with 1000 mg per day for 3 to 5 days, then switch to oral regimen. For glucocorticosteroid sparing, if the patient condition responds to glucocorticosteroid, we add azathioprine, methotrexate, mycophenolate, or cyclosporine. If response to glucocorticosteroid is insufficient, intravenous immunoglobulin 2 gram per kilogram in divided dose over a period of 2 to 5 consecutive days. And if response to glucocorticosteroid and intravenous immunoglobulin is insufficient, reevaluate and reconsider diagnosis. Initiate treatment with rituximab. If diagnosis is reconfirmed, recommend participation in a research trial. If disease does not respond to rituximab. And one more time, the treatment is glucocorticosteroid, DMARD, synthetic DMARD or biological DMARD, and also immunomodulin, intravenous immunoglobulin. In this slide, we see the heliotrope rash, we see the V-neck rash, we see the Gottron papules, we see the typical dermatomyositis overlap features with early scleroderma mark shining and erythema on the knuckles. And also, which is the very important part of anti-synthetas syndrome, we have interstitial lung disease in plain radiograph and in CT. Here you see the CT imaging of interstitial lung diseases. There is some flashcards for you to remember the dermatomyositis, polymyositis. Here, polymyositis, a rare idiopathic disorder characterized by striated muscle inflammation causing proximal muscle weakness. Dermatomyositis. If there is skin involvement in polymyositis, it is dermatomyositis. Derma is mean the skin. Causes of polymyositis. Incidence is 2 to 10 million and it occurs in all ages and races. Etiology is unknown, but viruses, for example, Coxsackie, rubella, influenza have been implicated. Agela, B8 and DR3 are genetically predisposed. Clinical features of adult polymyositis. Male to female is 1, 2, 3. Incidence months are acute onset. Proximal muscle weakness, shoulder and pelvic girdle muscles may become wasted but not tender. Can progress to pharyngeal, laryngeal and respiratory muscle weakness. Also malaise, weight loss and fever. Then, clinical features of adult dermatomyositis. You have also seen the heliotrope rash, the Gottron papules, the nail fold erythema, 25% have ulcerative vasculitis and subacute calcinosis. Also myalgia, polyarthritis and Raynaud's, long-term muscle fibrosis and contractures can cure. One more time about heliotrope rash. It is pathognomonic rash in dermatomyositis. Purple discoloration of the eyelids, which may be accompanied by periorbital edema. Also pathognomonic for dermatomyositis. And one more time about Godron's papules, raised purple-red vasculitis patches on the hands and knuckles, which occurs in 70% of patients with dermatomyositis, by very specific for the diseases. And anti-synthetase syndrome, 20 to 30% of patients with dermatomyositis or polymyositis have autoantibodies to tRNA synthetase enzymes. Anti-Joe increased risk of pulmonary fibrosis, Raynaud's arthritis, and Mechanics hand. 50% will also have esophageal involvement. This is a variant syndrome with a poor prognosis due to the combination of pulmonary fibrosis and weakened respiratory muscles. Cancer risk with polymyositis and dermatomyositis. As we said that we can have ovarian cancer, we can have non-Hodgkin lymphomas, we also can have melanomas and breast cancer in dermatomyositis, but not in polymyositis. We have finished lectures about dermatomyositis, polymyositis, and inclusive body myositis, and let's start the lecture about Sjogren's syndrome. What is the Sjogren syndrome? Well, Sjogren syndrome is a chronic, slowly progressive autoimmune disease characterized by lymphocytic infiltration of the exocrine glands, resulting in xerostomia and dry eyes. Approximately 1/3 of patients present with systemic manifestation. Pay attention that it is not only dry mouth or dry eyes. These diseases also have systemic manifestations. A small but significant number of patients develop malignant lymphoma. The disease present alone when we talk about primary Sjogren syndrome or in association with other autoimmune rheumatic disease, secondary Sjogren syndrome. Most of time we have association with rheumatoid arthritis. Middle-aged woman, female to male ratio is 9:1. Are primarily affected, although Sjogren syndrome may occur at any age, including childhood. The prevalence of primary Sjogren syndrome is 0.5 to 1%, while 30% of patients with autoimmune rheumatic disease suffer from secondary Sjogren syndrome. And also in this slide you see the ways Sjogren can affect the body. We have peripheral neuropathy, the renal phenomenon, vaginal dryness, vulvodynia, stomach upset, arthritis, bronchitis. We can have difficulty swallowing, heartburn, reflux, esophagitis, swollen, painful parotidal-salivary glands, dry eyes, corneal ulceration, infection. We can have caries and some dental problems, dry mouth, fatigue, vasculitis of skin, and so on. In pathogenesis, we are talking about lymphocytic infiltration of the exocrine glands and B lymphocyte hyperreactivity. Autoantibodies to non-organ specific antigens such as immunoglobulins, for example, rheumatoid factor in high titers, and extractable nuclear and cytoplasmatic antigen, ROSSA, LASSB. ROSSA autoantigen consists of two polypeptides, 52 and 60 kilodalton respectively, in conjunction with cytoplasmatic RNAs, whereas the 48 kilodalton of LASSB protein is bound to RNA 3 polymerase transcripts. And also the HLA-B8, HLA-DW3, and interleukin 1, 6, and TNF-alpha have role in pathogenesis of Sjogren syndrome. In diagram, you see the antigen-presenting cells, some cytokines, autoantibodies that can have a role in pathogenesis of Sjogren disease. Well, let's discuss the clinical features of Sjogren syndrome. Most individuals with Sjogren syndrome present with Zika symptoms. Zika, it means dry, such as xerophthalmia, dry eyes, xerostomia, dry mouth, and parotid gland enlargement, which is seen in the image below. In the image, you see the enlargement of parotid glands and also the dry mouth or xerostomia. As I said, we have not only glandular features, but we have also extraglandular features in Sjogren syndrome. It is the arthralgia, arthritis, Raynaud phenomenon, myalgias, pulmonary disease, gastrointestinal disease, leukopenia, anemia, lymphadenopathy, neuropathy, vasculitis, renal tubular acidosis, and lymphomas. Some cutaneous findings: dry skin, xeroderma, palpable and non-palpable purpura, and or urticaria. Photograph that demonstrate the Schirmer test, which is used to detect deficient tear production in patients with Sjogren syndrome. Well, the filter paper strip is placed at the junction of the eyelid margins. After 5 minutes, 15 mm of paper should be moistened if tear production is normal as shown here. Persons older than 40 years may moisten between 10 mm and 15 mm. Patients with Sjogren syndrome have less moistening. Sjogren syndrome is most common in patients with rheumatoid arthritis, but may also occur without associated disease and in systemic lupus erythematosus, polyarthritis, systemic sclerosis, lymphoma, and sarcoidosis. Well, etiology. Viruses are viable candidates as environmental triggers, although proof of causation has remained elusive and certainly no single virus has been implicated. Epstein-Barr virus, HTLV1, human herpes virus 6, HIV, hepatitis C virus, and cytomegalovirus may have a role. Sjogren-like syndromes are seen in patients infected with HIV, HTLV1, and hepatitis C. Diagnostic criteria. The patient presents with eye and or mouth dryness. Eye test disclose keratoconjunctivitis Zika. Mouth evaluation reveals the classic manifestation of the syndrome and or the patient's serum react with ARO-SSA and or LASSB autoantigens. Labial biopsy. Validated diagnostic criteria have been established by a European study and have now been further improved by a European American study group. Hepatitis C virus infection should be ruled out since apart from serologic tests. The clinical pathologic picture is also identical to that of Sjogren syndrome. Enlargement of major salivary glands, particularly in seronegative patients, should raise the suspicion of immunoglobulin G4 related syndrome, which may present also as chronic pancreatitis, interstitial nephritis, retroperitoneal fibrosis, and aortitis. Let's talk a little about treatment algorithm for Sjogren syndrome. When we have glandular manifestation, in glandular manifestation, we think about dry eyes, dry mouth, and parotid gland enlargement. When we have dry eyes, we should avoid smoking areas, windy, low humidity environment, drugs with anticholinergic action, diuretics. Lubrication, artificial tears without preservatives, bicarbonate buffered electrolyte solutions, local stimulation, cyclic adenosine monophosphate, cyclosporin 2% olive solution. Systemic stimulation, pilocarpine 5 mg thrice daily orally, cevimeline 30 mg thrice daily orally. And when we have severe dry eyes, we should use nasolacrimal duct occlusion, temporary or permanent soft contact lenses, corneal transplantation. When we talk about dry mouth, oral hygiene after each meal, topical application of fluoride, lubrication such as water, local stimulation, sugar-free gum, systemic stimulation. As for dry eyes, pilocarpine 5 mg thrice daily orally or cevimeline 30 mg thrice daily orally. Oral candidiasis, we use topical nystatin or clotrimazole lozenges. When we had parotid gland enlargement, we should apply local wet heat, treat super infection by antibiotics or analgesics, persistent and hard, rule out lymphoma. When we talk about extraglandular manifestation, when we have arthritis, hydroxychloroquine or methotrexate plus prednisolone. Raynaud's phenomenon, cold protection, gloves, and nifedipine 10 mg thrice daily. Renal tubular acidosis, bicarbonate replacement, vasculitis, standard treatment, lymphoma, CHOP plus anti-CD20. Here is some manifestation of Sjogren syndrome. Sjogren syndrome with keratoconjunctivitis sicca, severe Sjogren syndrome, dry eyes, dry mouth, and connective tissue disease is associated in some cases with secondary problems in the conjunctiva. In the majority of patients with SLE, severe sicca syndrome is unusual. In Sjogren syndrome with xerostomia associated with dental caries, dryness of the mouth and inadequate saliva formation result in a tendency to dental caries. For patients with primary Sjogren syndrome and those with lupus and SIGA, dental care must be fastidious. And some flashcards for remember the information. What is Sjogren syndrome? Well, a long-term autoimmune disease in which the moisture-producing glands of the body are affected. This is results primarily in the development of a dry mouth and dry eyes. What is the general pathophysiology behind Sjogren syndrome? The exocrine glands are affected in a destructive fibrosing process leading to failure of gland function. The pathological findings are of focal lymphocytic infiltration in the exocrine glands, salivary glands, sweat glands. What are clinical features of Sjogren syndrome? It's sicca symptoms, vaginal dryness, dry cough, dysphagia, systemic upset, arthralgia, and so on. What investigation would you do if you suspected Sjogren syndrome? We must do blood test. We must find anti-Rho, anti-La, anti-nuclear antibody, rheumatoid factor, elevation of CRP, ECR, Schirmer test, Rosebangas staining, and biopsy. Which antibodies are most commonly associated with Sjogren? We have also known anti-Rho, anti-La, anti-nuclear antibodies, rheumatoid factor. And conclusion. Thank you for pay attention in our lectures.